invite Dr. Charles Buchanan, who is going to talk us through managing your Addison's disease.
Good afternoon. Hands up who's got Addison's disease if you're proud to announce it or otherwise. It's not that difficult to manage, is it? You think? No. So I'm in the best position. I've got positive treatment that is easy, has a very few simple rules. And as long as you educate the parents and the patients as they grow up, it's one of the favourite conditions I kind of look after. This is where I work, down in Kings in South London. I've been there for 23 years, setting up a regional endocrine service for paediatrics. I have a catchment of about 3.5 million patients. This is Thomas Addison, who described Addison's disease back in 1855. It couldn't be treated until the late 1940s, when we were first able to make the cortisol, the missing hormone. Excuse my throat. So my experience in these 25 years, personally, I've worked with 3 families, both with 2 affected boys, 2 early onset families, 1 teenage onset, and 1 whose mother's in this room had a very successful bone marrow transplant, but not without some hard work along the way. In context with real Addison's disease, I've got about 15 children passed through my care or still under my care. All but 2 have autoimmune Addison's disease, which is the commonest type. But essentially the treatments are almost identical for Addison's with ALD and Addison's that's autoimmune. And my wider experience is with about 75 patients with congenital adrenal hyperplasia, which is essentially biochemically the same but of variable severity, sometimes complete hormone deficiencies, sometimes relatively mild. But essentially from these patients is where I get my day-to-day experience of trying to get treatment ideal or as idealised as possible. And we've got a few other rare conditions because we're in a specialist centre. Brief bit of physiology. The adrenal gland sits on top of the kidney, that's why it's called down on top of the kidney. It's regulated from the glucocorticoid, that's cortisol, and the mineralocorticoid by the hypothalamus and the pituitary through ACTH, which was in that synacthin test that you heard about earlier. Cortisol controls essentially blood glucose and blood vascular tone to help the blood pressure. And the aldosterone controls salt reabsorption through the kidney, and that's another little loop that requires the kidney to recognise low blood pressure, produce this hormone renin, and it goes through the lungs and comes back to the adrenal gland to tell it to make aldosterone, which goes back to the kidney and tells it, oh, don't it's salt. ALD, as you've already heard, long-chain fatty acids cause damage. You've already heard how we might expect a presentation of Addison's, some through somewhat vague progressive symptoms that are very non-specific and can lead to delayed diagnosis because presumption there's other less significant conditions. And the vast majority in our paediatric population present with Addisonian crisis, collapse, postural hypertension, abnormal electrolytes, dehydrated. Thankfully in my region, they've all been rescued from death by the good local units. None of them have presented at my hospital, they've all presented to regional units, and the local services have had to work out the diagnosis, send them into intensive care in central London, and then we pick up the pieces. Screening, of course, is the other way of finding it with ALD, and as soon as we know of any boy with ALD, then hopefully the relevant neurology teams make sure, as you already heard, that the endocrinologist gets involved and works out whether we should worry about coexisting adrenal insufficiency. Ideally, we'd use the short synacthin test, which you've heard about, which takes just 30 minutes, and unlike long-chain fatty acids, we get the result back within 2 hours if we ask the lab to give us the answer. So hopefully no child's going to go home undiagnosed, untreated. Plasma-renin activity to look for evidence of need for the aldosterone replacement. That can take about a week to come back, and occasionally gets lost in the system. Screening, you heard from our Dutch colleagues as to whether or not you should be screening using just a morning cortisol with ACTH, and this does in fact work if you have already got established adrenal insufficiency, because if the ACTH level coming from the pituitary is higher than your reference range, and the cortisol level is within or below the reference range for 9 AM, you've got a diagnosis. And if you want to know just how bad it is, you then do the short synacthin test. So if you want to integrate something in an annual screening for your adults, just a baseline morning cortisol and ACTH paired, does work, it has usefulness. So I've just mentioned about this bit, and the elevated plasminogen activity with a normal but inappropriately low aldosterone and abnormal electrolytes. Thereafter, you've got to decide what's the cause of this Addison's disease. Well, the vast majority are going to be autoimmune, and there may be associated autoimmune disorders in the family history or pre-existing in the child. It's routine, or should be, in paediatrics to measure the autoantibodies. They're against the steroid synthesis pathway in the adrenal glands. And if they come back positive, which should be within a week, then you know you've got autoimmune disease. In practice, if we already know from a synaptin test that a child's got adrenal insufficiency, we make sure we get the long-chain fatty acids sent off with all the bloods to get the fastest return possible. There are other rare genetic causes that we may have to look into if the top two don't come back positive. Or rather, one of the top two doesn't come back positive. History tells us much. The risk of progression from Addison's on its own to recognizing you've got ALD or the spinal form was very well pointed out way back in 1996, and there's no reason that anybody since then with a child with onset of ALD should not be measuring, rather with childhood onset Addison's should not be measuring very long chain fatty acids. And that was reinforced back in 2001 by my colleagues working in Bristol, who found that 80% of the children with Addison's disease that was unexplained by autoimmune pathology turned out to have ALD. But some of those were only then being picked up as young adults with the spinal form. So our management aims, once we've made a diagnosis of adrenal insufficiency or Addison's, first of all, the family have to know that this is a lifelong, life-threatening condition, and work your way through repeated education to try and give them reassurance that if they heed our advice as doctors and nurses within the team, there's a very good prognosis for a healthy, normal, active life and lifespan. Standard replacement these days is with hydrocortisone, 2 or 3 doses a day, kept at approximate physiological replacement levels in 2 or 3 doses, individualized to suit the lifestyle, the symptoms, how well that child is. Cortisone acetate is old-fashioned but still available and used in some countries that prefer not to use the more expensive hydrocortisone, but it takes about half an hour to get metabolized in the liver to be as active as the hydrocortisone. And that's meant to be taken first dose of the day as soon as you wake up, and within an hour you've got the energy to get up and go to school. Prednisone is a longer-acting, stronger glucocorticoid, which doesn't have the same effect as hydrocortisone to help retain a little bit of salt, but it's very useful in teenagers that don't want to take tablets 2 or 3 times a day. And then we have to put back the missing aldosterone, which is to retain salt through the kidneys. We have a synthetic version which is more potent than aldosterone and is much easier to measure. So this is what we use, glucocortisone, just once a day in the morning. And importantly, we don't know how much salt an individual needs, so we say keep it on the table, eat as many crisps as you feel you like, satisfy your cravings for salt if you have any, but don't worry about it causing a bit of problem with high blood pressure. It's more important that you get enough salt in your body in the first place. So, fludrocortisone, start with this, it's the easy one. It comes in a bottle, that's what aldosterone looks like, and the reason this is more potent is that little H there for hydrogen has been converted to an F for fluorine, which if you stick a halogen like fluorine or chlorine in any steroid molecule, it will be stronger, it will be more potent than otherwise it would have been. This fluorine F product was remanufactured by a slightly different process a few years ago, and they insist that you keep it in the fridge. However, its loss of potency is 0.1% over 6 months if you choose to leave it out the fridge, so don't worry about it. How do we monitor it? It's simple. Blood pressure, to make sure we're not giving too much, but blood pressure comes in reference ranges. We're more interested in the physiological feedback, so get the plasma reading within the normal range once a year, once you've got a dose that works in a growing child. Once you're grown up, you probably don't need to measure it at all, as long as the doctors know you're really taking the tablets. And the patient knows that as well. Replacing hydrocortisone is a bit more tricky because there is a natural, what we call diurnal rhythm. Nothing at midnight coming into your blood, body wakes up 3 or 4 in the morning, peaks about 8, 9, 10 in the morning, comes down and drifts and repeats that cycle. And if you take 3 tablets, one's a big one in the morning, a little less at lunchtime, a little less in the evening, there's no way you can replicate that natural rhythm. So in recent years, to avoid some of the side effects potential of long-term overdosing, to guarantee enough through most of the day, and that would be potential obesity, potential thinning of the bones, osteoporosis. There are some drug companies working on 2 products, one now on the market called Prednisone, and one almost here called Chronocort, that have delayed absorption. And for the Chronocort device, if you take your tablet at bedtime after you brush your teeth, it starts to get absorbed in the middle of the night and wears off before the end of the next day. So if you really want to get close to nature, you take a big tablet at night and a little one in the morning, and that gives you almost near perfect profile. The problem at the moment is these tablets, because of their delayed absorption, they cannot be broken into bits to give you smaller doses. So for pediatric population, both teams that manufacture these products are working on smaller tablets to start treating from as young as birth in some of the congenital conditions. Monitoring and treatment in childhood, height and weight to make sure a child's following a normal steady growth pattern, and a healthy child from the age of 2 will follow the same height channel and the same weight channel until they get to puberty, if everything is in order. So that's fairly straightforward. I've already mentioned about monitoring your fludrocortisone dose, and for hydrocortisone replacement, some people do the odd blood test, maybe profiles 2 or 3 blood samples through the day. That takes time, it takes money, it takes a day out of a child's life, out of school, the family life. So primarily, you go and how does this child feel? Energy to do everything they want to do? Do they feel tired in the evening? Do they get a headache? Is there anything that suggests they're not quite tip-top shape? And fine-tune, as one does with years of experience. He says modestly. Somebody with complex medical diseases, you do have to be aware there's a few drug interactions, notably anti-epilepsy, barbiturates and anticonvulsants may need more hydrocortisone, and keep away from grapefruit juice and licorice, which somehow interfere with the receptors for hydrocortisone and may need dose adjustment. And then if you're on fludrocortisone as well, obviously, anything that affects throughput of electrolytes and water through the kidneys, and again you've got licorice in there again, and some non-steroidal anti-inflammatory drugs can interfere with metabolism, so it's best to keep away from those. Treatment problems. Some children don't like the taste, some GPs don't like the expense. Hydrocortisone is now £2 a tablet. If you're on one of those long-acting tablets, they're £8 a tablet, so the cost of replacement is about £10,000 a year for some of them. Hydrocortisone requires frequent doses through the day, I've already mentioned. Prednisone does last long, as I mentioned, and helps for compliance in the teenagers, but we don't want to introduce risks of side effects. About the only change to treatment in the last 50 years has been the introduction of these long-acting formulations. That's as much excitement as we get in our business in paediatric endocrinology, but to be honest, it's good. So, one of the big worries when we tell families their child's got a life-threatening disease is, when is it going to get into a crisis? This comes about if you don't take your tablets, if you have intercurrent illness, if somebody forgets to give you your tablets when you're admitted to hospital for something else, if they don't give you an extra shot for operations and anaesthetics. And the good news is relax, just listen to your doctors and your nurses and have emergency management in plan. This paper here is just published, a 30-year experience through Utrecht, obviously good doctors there, and in their 3 groups of adrenal insufficiency, the primary Addison's type had only 5 episodes of adrenal crisis in 100 patient years, and that's over 100 patients. If you have hypopituitarism, it's a little bit less because you don't have the problem of salt loss, and if you've been on steroids for some rheumatoid arthritis or cancer, you've got much greater risk, 3 times fold greater, because you have more comorbidities. One has to say that would apply to the child with ALD that has already got brain disease. So we have to preempt adrenal crisis, sick day management, treat the underlying cause, have a very low threshold to respond to fever, and if you're going to be vomiting and not keeping your tablets down, get to hospital. If you're not that bad, you can stay at home with your flu, double or treble your hydrocortisone, but leave the fludrocortisone unchanged. If you do have a bit of diarrhea and you switch to diaurolite, there's not enough glucose there if you're not eating properly, so for the under 5-year-olds, you'd very likely need to be in hospital. We have emergency packs, which the families keep at home and at school, containing dextrose gel, injection of glucagon, which gets sugar out of the liver. and also hydrocortisone to be given IM or rectally sometimes at home and on the way into hospital. All patients are what we call a TWIMC, that's a to whom it may concern, summary of their diagnosis, current treatments, and 4 paragraphs to say, treat this child quickly and promptly in triage, check the sugar level, get a drip up, give them salty water, give them dextrose if they need it, give them a shot of hydrocortisone, and then think about what you're going to do with them later. And the don't be shy is much to be repeated. Despite these letters, which have my name and on-call phone number, there are casualty teams that leave the patient sitting in the corner because they think the guy with the sore thumb is more problematic than this chap who's maybe a 6-month baby that had a couple of vomits. So the parents are told to make sure they grab the local team and say, please ring my consultant, and say his thing. Our local ambulance services in London and many in the country have a database that will take a register of all patients with steroid-dependent illnesses. So with their consent, they know what the diagnosis is, they know what their current treatment is. They have the child's postcode at home and the child's postcode at school. So if the call comes in 999, they know that that child needs the proper ambulance with somebody that can do injections and or put a drip up if needed. Very simple strategy. Extra precautions, medical tags. Some adults and children don't like wearing them, but it's an insurance policy. Having a steroid card in your wallet's not a lot of help when you've been knocked over and you're on your own. Plan ahead for any elective surgery, anaesthetics, etc. That's part of the emergency letter. If you're travelling abroad, carry 2 lots of everything. It's just like the diabetics. 1 set in mum's bag, 1 set in dad's bag, and even a 3rd set in the child's bag, depending on where you're going. And additional immunisations that aren't part of the ordinary setup for paediatrics in the UK. Finally, the patients are out there. We don't live with them. They learn a lot from each other and other families. In the paediatric world, the congenital adrenal hyperplasia support group are probably the best to turn to because they have a large volume of patients and they have a very good contact network, and dealing with CAH is actually harder than dealing with Addison's because there are more subtleties about how we're trying to regulate the 24-hour hormone balance. And if you don't want to believe anything I've said, you can turn to 2 consensus statements on how to diagnose and manage the treatment of Addison's disease. The Europeans came in first in 2014. The Americans followed with publications just in January this year. And they do both specify that if you don't know the cause of your Addison's, for goodness sake, make sure it's not ALD, because you've got a window to get in before things get worse. I'm more than happy to release my PowerPoint on to the team here to make available to everyone so they can check all those references. And thank you very much.
Thank you.